Hello, and welcome to today's i3 Health and Oncology Data Advisor interview. Today, I'm joined by Dr. Filipa Lynce and Catherine Skefos, who are the two co-chairs of i3 Health's activity titled Pathways to Precision, Integrating Genetic Counseling and Testing into Cancer Care. They're here today to share some updates that have occurred since this activity was recorded and some additional insights and expertise on these topics. So thank you both so much for joining this interview today. We can begin with each of you introducing yourselves and sharing what you do. If you'd like to start, Dr. Lynce.
Sure. My name is Filipa Lynce. I'm a breast medical oncologist at Dana-Farber Cancer Institute, and I am a member of our BRCA Center. Happy to be here with you today.
And my name is Catherine Skefos. I am a senior genetic counselor at MD Anderson Cancer Center, and I specialize in endocrine genetic counseling and testing, although I see patients with a very wide range of different family histories and personal histories of cancer.
Great, looking forward to talking with you both today. So Catherine, we'll start off with you. Since the recording this activity last November, have there been any new insights you'd like to share that weren't covered in this activity?
So one thing we didn't touch on too much in the previous presentation, and a relatively recent update to the field of genetic testing, is the availability of RNA testing to go alongside DNA testing for cancer panels. So although RNA testing is not going to make a difference for the vast majority of patients, it may help in certain situations. For example, if your patient undergoes genetic testing and their results show a variant of uncertain significance, specifically a splice site variant, where the lab is not quite clear on whether or not it's pathogenic, additional RNA testing may help to disambiguate that type of result. So I would encourage people, if you do get that type of variant on a patient's report, you can consider contacting the genetic testing lab to ask them if they think that RNA analysis might help to gather more information about the clinical relevance of that particular genetic difference. Another topic that I think deserves a little bit extra attention is the topic of what to do if your patient's test comes back negative. So a couple of suggestions that I would have for clinicians is one, to determine if there's someone else in the family whose test result may be more informative. So if your patient is unaffected but underwent genetic testing due to a family history of breast cancer, is there a living relative who had breast cancer who might be open to genetic testing? That can really help clarify the source of cancer risk in the family. You can also consider using risk models such as Tyrer-Cuzick or the Gale model for unaffected females to help estimate lifetime cancer risk and determine whether they're eligible for high-risk breast screening. And then lastly, depending on when your patient had genetic testing, you can also consider updated testing for them. So for example, if they only had BRCA1 and 2 testing back in, say, the 2010s, they may benefit from updated panel testing. And I often have people ask me, how often should my patients get updated testing? But there really is no set timeline for this. I typically would look at the testing that was done in the past, compare it to the panel that's available now, and sort of ask myself, if a mutation were found in one of these newer genes, would that impact the patient's or their family's care? And if the answer to that is yes, then it's probably a good time to consider updated testing.
Awesome. These are really great insights. So thanks so much for sharing with us. Awesome. And then Dr. Lynce, have there been any updates to the trials that were discussed in the activity or any upcoming research on the horizon?
So actually, I can tell you about, one of the trials that I shared with you, that was the Olympia, looking at the taking olaparib, a PARP inhibitor, for 1 year for those patients that had completed chemotherapy and had early stage breast cancer. And we went over the results. But since our activity, mid-December at the San Antonio Breast Cancer Symposium, we heard an update of this trial, and we all learned that at a median follow-up of 6.1 years, so, longer follow-up than what we had seen before, the results continue to show a benefit of those that took 1 year of olaparib compared to those that did not. And in particular, what we learned was that those patients that took olaparib for 1 year the use of olaparib was associated with a reduction in the risk of death by 28%. So it was, compared to those that did not take it. So we continue to see benefits. So it's nothing that was transitory over the time, even after you are off the olaparib. We see that there was a benefit, and pretty much all the other endpoints of the study continue to favor the use of olaparib for 1 year versus not. So this is definitely a reason why we should be testing all our patients with breast cancer, that if we learn that they have a BRCA mutation, they would be eligible for this drug. I don't think that we talked about it. In our activity, we spoke about these new drug, this new class of drugs, the PARP1 selective inhibitors, that are expected to be a newer generation of the PARP inhibitors. And now there is a large phase 3 trial that it's enrolling pretty much all over the country, and it's a global study that it's comparing the use of a PARP1 selective inhibitor with endocrine therapy versus CDK inhibitors with endocrine therapy, that it's pretty much our standard of care. So it's called EvoPARP Breast 1. So if you have it around, if you've heard about this study, if you might be eligible, check it out, and have it in mind for your patients as well.
Amazing. Exciting to hear these favorable updates and the new research to look forward to. So for going back to Catherine, over the last 6 months or so, have you found any new resources or tools or strategies to be helpful in staying current or improving care in this area?
One thing that I've noticed as sort of a trend over the past 6 months to a year is the uptick in social media creators that are sharing their stories with things like genetic testing results, prophylactic surgeries, cancer treatment, different things like that, as well as oncologists who are sharing their expertise via social media. I think this is something that is here to stay, and that is not just a sort of a passing trend. So I think that as clinicians, we need to sort of keep our finger on that just a little bit to kind of be aware that patients may be gathering a lot of information. They may come to us with questions about specific trials or specific genes. Was I tested for this because I heard about this online and want to make sure that that was covered in my testing. So just being open to that, being aware of that, not dismissing it because it's, that's just silly social media. This is really a valuable area and outlet for a lot of people in this world of sort of rare things like genetic testing, positive genetic testing results. So I think that's something that we can continue to just keep track of a little bit on the side, to stay current and be there for our patients if they have questions about that.
That's a great point, especially as you mentioned, as this role of social media is evolving and here to stay. So for each of you, looking ahead, what are some of the trends or developments that you anticipate will shape this field in the near future, and how should clinicians prepare for them?
Great question. So I think that we'll continue to see more results of these studies with PARP1 selective inhibitors. I talked to you about the Petra study. We had seen just the initial results, and I suspect that we'll continue to see more later this year and next year. So something to be on the look for, and how we are going to incorporate this. And I think the other thing that we are going to see more is people using more liquid biopsies, where we are going to find out BRCA or PALB2 mutations, and keeping your mind thinking, is this a germline mutation that I'm picking up on the blood, and that should reflect germline testing because these will be important for the rest of the family? Or is this just a somatic mutation, but patients, based on the data that we have, might still benefit from a PARP inhibitor? So this will imply that, all the providers, APPs, physicians, when they look at the liquid biopsies that we are getting more and more for patients with cancer, that they keep their genetics hat, thinking about what are the implications for the family of this patient.
Absolutely. And I would echo what Dr. Lynce said about the importance of somatic testing and cell-free DNA testing, with that possibility of identifying a secondary germline finding. And I think that it would be helpful for clinicians to know that they can always call the lab where the testing was done to get any additional insight if there is a question about whether a particular variant may be germline or not. The lab is often a great source to go to gather as much information about that as possible.
Absolutely. And then as we wrap up today, why do each of you encourage the audience to take this activity, and why is it important to stay up to date on these topics?
I think that this is information that is out there that patients are becoming more and more aware of. And so taking or being part of an activity like this can help clinicians to develop that baseline knowledge to be able to share with patients who likely have a lot of questions about things like inherited risk and how might this impact my family, my treatment, my future risk. And so I think that this activity is a great intro to both sides of the coin. How might this impact my hereditary risk, my family's risk, but also how can this be useful for my treatment as well?
I totally second that. So I think that no matter what is your role, what you dedicate to, what is, the pathology that you see more often, it's really hard to stay away from genetics because that impacts what you do and the patients you take care of in so many forms. And the questions arise, no matter, if you take care of breast cancer, prostate, hematological malignancies, these questions will come. And I think that this is a great start to get deeper into these fields.
Absolutely. So thank you both so much for sharing these insights with us. It's great to hear about how the field is evolving. And to everybody listening, be sure to visit i3health.com or scan the QR code that will be at the end of this video to view the full activity and claim your free CE credit. So thanks again, and it was wonderful to talk with you both today.
Thank you, Kira.
Thank you, Kira. Great to see you again.